Hi, welcome to the MuniMeterHealth.com, my website, which is dedicated to Cardio 360 video series of my library on Facebook and on YouTube that you're watching, learning, and sharing with your friends. This is Dr. Jaitly, my dear friends, specifically the interns, the residents, the fellows, and the cardiology colleagues, and also the ones who are not in cardiac field but would like to know about the human heart. You're all welcome to attend and learn on this quick video vignette. The condition today that I'm going to be talking about is peri-partum cardiomyopathy, which is pregnancy-related heart failure. The heart failure that develops within the last trimester of the pregnancy and lasts until the 6 months post-delivery is by definition known as peri-partum cardiomyopathy. Now, we know that it's a very unfortunate condition that the lady delivers and then at the same time, unfortunately, gets inflicted with this heart failure condition. It's a very, very precarious condition, obviously, and it's one of the major causes of pregnancy-related deaths in the women in the U.S. And the maternal mortality could be anywhere between 10 to 15%. So it is a very important entity and yet needs to be recognized and attended to rather quickly with all the measures that one can apply. So it's very important for us to recognize this, whether it's a layperson or whether in the cardiology field. It's a good know-how for all of you to quickly understand what this condition is all about. Well, one of the things that immediately comes to your mind is why should a young lady who's delivering a baby develop a heart failure? Well, either the woman started to have a valvular heart condition to begin with, which led to get worsened during the time of pregnancy because the demands were so high when the fetus was growing within the womb, and or other causes of cardiomyopathies or heart failures, we call it, simple terms, where either there was a viral infection or other ongoing myocarditis, we call it, which may have weakened the left ventricle, which is the booster chamber of the heart as shown here on the left panel. Having said that, sometimes we don't have a cause. And we don't have a cause, that's where you begin to wonder and start thinking on peri-partum cardiomyopathy. What is the cause here? It's not a valvular condition. It is a condition where there is an autoimmune exchange that may have occurred. This is a hypothesis now. Note that. This is a hypothesis. This is where we think that the fetal antigens, they cross the placenta barrier and create an antibody reaction in the mother's plasma. And as a result, the heart senses those antibodies and starts reacting by causing a cardiomyopathic reaction, if you will, pathologically or pathophysiologically. So it is the hypothesis, and that's what his autoimmune phenomenon is. And sometimes it has been also linked to some viruses, we don't know, but we know that it is prevalent in African American populations to a higher degree, also seen in Africa, and sometimes it's preceded by gestational hypertension. That means during the pregnancy, if the woman tends to develop high blood pressure, tends to run a pressure which is in a range which requires some treatment. Invariably, the woman is more than the age of 30 when she develops this, or at the time of the pregnancy. And it's known to recur in pregnancies thereafter. So it's a big no after once the peri-partum cardiomyopathy has developed in the woman and the lady has delivered the baby. After that, the counseling by the OBGYNs are so paramountly important that one should discourage any further pregnancies because it's a recurrent chances are extremely, extremely high. Now, if the pregnancy goes well, you try to deliver the baby as soon as the heart failure is diagnosed. That's one more caveat here. One thing to remember as part of the therapy, that try to deliver within the third trimester, sooner if diagnosed, as long as the baby has developed well by all standards by the OB assessments. Now, a standard heart failure therapy will immediately apply. Obviously, using the diuretics, if need be, if there's a volume There's a lot of swelling, etc., in the feet, in the ankles, or there's volume expansion within the lungs, etc. You will have to use beta blockers, and of course, ACE and ARBs are indicated only after the baby delivers, after the baby is born. Now, there are other drugs that have been implicated, which are TNF alpha inhibitors and pentoxifylline. Sometimes anticoagulation is necessary if one sees a clot within the left atrium, because remember, the blood is going to be stagnant if this left ventricle becomes weak. And sometimes ejection fraction normally should be 50% and over. Here you have less than 35%, for instance. Just hypothetically, I'm giving an example. The ejection fraction is 35% or less. That is considered as a severe heart failure, and the left atrium can start showing some smoke, we call it, or sometimes a clot. And when that happens, you're better off putting an anticoagulation in that young lady. Otherwise, there's an unfortunately high incidence of having a stroke in that individual. Prolactin inhibitors like bromocriptine have been tried well, and they seem to be working good. But again, survival patterns have yet to be shown, both for pentoxifylline and bromocriptine drugs. But standard heart failure therapy should be instituted as soon as possible if the baby is already delivered and born. Heart transplantation is the other definitive way of treating this patient, specifically so if the heart failure persists after 6 months and the patient is not improving and the ejection fraction is not budging, then you're better off considering the woman for a heart transplant list, because one, she's young, and two, she's free from all other systemic illnesses, so she's a perfect candidate for a recipient heart, for a donor heart to come in, and as a result, she should be placed on the waiting list if the ejection fraction is less than 35% even after 6 months. But normally, the good news is here now, 50% of all these heart failures will improve within the 6 months. But it's the other 50% that we have to worry about. So there is a higher incidence of still persistent heart failures, but 50% will totally resolve, up to 50% will totally resolve in the first 6 months of the delivery. Now, the incidence somebody would like to know, just curiosities with numbers, if somebody wants to remember, it's 1 in 1,500 pregnancies. So there is a fairly low, fortunately, incidence, but still worth keeping in mind, specifically in these populations we just discussed. And the coronaries are clean, like I've shown you here in the left lower panel. The coronaries are clean, so there is no ischemia. The left ventricle on the upper panel, as I show you here, that's the one which takes the brunt. We know the heart has 4 chambers, but being the left ventricle, the booster chamber, that's the one which really suffers the most. The heart failure usually implies that you have an issue with the left ventricle, which may show some dyskinesia at times. That means the walls are not moving or encroaching within the ventricle simultaneously. So this wall instead of moving inwards, it's moving outwards like this. And this wall is coming in during the contraction phase. So sometimes we have advocated even cardiac resynchronization therapy called CRT, where a wire is placed into the heart in order to stimulate the 2 walls of the left ventricle right here, and they can synergize, if you will, and they work in concert and try to effectively improve the ejection fraction on the individual. So this way the lady can come off some of the heart failure medications over a period of time, and certainly improves the survival pattern. Here's a pathophysiology as to how the heart failure sets in, because normally the end-diastolic volume, for instance, is 150 cc's, which is the total resting volume of this ventricle, for instance. And when it ejects, it has ejected 80 cc's, for instance, so the remaining volume is still 70 cc's. Remember, the ventricle is never empty. You still have, it's not like an empty ventricle. It contracts, but still has a residual volume, and that is the end systolic volume. That means at the end of systole and the end of contraction. So the ejection fraction essentially is, it's a little math here now, 80 over 150 times 100, that gives you about 53%. Okay, so that's a normal ejection fraction. But in a setting where the heart failure is present, like the peri-partum cardiomyopathy or any other heart failure, you will see the stroke volume will diminish 60 cc's because the residual volume still remains high, it's about 90. We know the starting volume was 150 ml, so it reduces to 90 only, and then the stroke volume therefore is much lower than the previous one, and therefore the ejection fraction is 60 over 150 times 100, that is 40%. So there's just a little math for the students and residents, but don't pay too much attention if you are not interested into any of that stuff. But the fact is that, just remember that it's a fairly, fairly not so common incidence, but still worth tending to and noting to, because obviously it's the highest risk in maternal mortality seen in the US even today. In terms of pregnancy-related deaths in the mothers, and it's about 10 to 15%. But the good news is, 50% of these cases will improve within the 6 months, and the others will require some anti-heart failure therapy for a while, or for a long number of months and years sometimes. And they could be candidates for cardiac transplants if the heart failure fails to improve and just progresses to worsen further. Especially in a young female, you have to consider heart transplantation as a definitive therapy in these individuals. Okay, hope all of this information is very helpful. Please go back and supplement with the texts and journals and other articles that you like to associate peri-partum cardiomyopathy with. I thank you again for watching MuniMeterHealth.com on Facebook and YouTube. Please continue watching, learning, and sharing with your friends. And of course, hit that like button if you enjoyed this. And of course, subscribe to my channel on YouTube. The website again, MuniMeterHealth.com. This is Dr. Jaitly from New York. See you again on my next presentation.